today, and I'm going to call to order. This is the first hearing of the Senate Select Committee on Children and Youth with Special Needs. Very appreciative of the interest here in this particular topic, and certainly as a pediatrician and a father, obviously one that's very near and dear to myself. I know that many of the other members of the committee also are very interested in today's hearing, of course being off session. I think people are in various places, but I know that they have all expressed interest in getting the information from this hearing, and so I'm very appreciative of that. Obviously, when it comes to the children, while certainly parents in almost most cases have primacy in the care and raising of their children, certainly the state plays a very major role, whether we're talking about educating children through our public education system and supports we also provide through special education to healthcare, where our Medi-Cal program actually covers about half of all children in the state. Developmental services, mental health. The state of California plays an extremely important and role in ensuring that providing supports for families and providing the services for children and their families. And while we're doing that, California, unfortunately, certainly has many challenges. We still struggle with high rates of child poverty. We have challenges in terms of ensuring that families have their supports in our education programs as we had come out of the recession. But even amongst all the children, certainly we have children with special needs. And those are children who need more than just we call it the usual supports, but children who have a variety of additional needs that their families may or may not have the capacity to try to address. And in fact, often when we think about that, we think about sort of the universe of different types of services and supports that we provide. And in fact, as far as this select committee is concerned, we're sort of broadly put them into four sort of major categories. I think one can argue about there's probably several subcategories, but I think about the role of the state. We have certainly healthcare, including the CCS program for subspecialty care. We have mental health. We have our developmental services, and we also have our education system, particularly special education. And all of those, when it comes to families, although we can talk about how these are separate buckets and within each bucket how they're subdivided, for the families, they're thinking about how do I take care of my kid, right? And how do I be sure that my child gets the help they need? And I'm sure we'll be hearing from a parent of a child with special need that it's probably less about the buckets from their perspective. It's about how do we make this all connect and work together so my child has every opportunity to achieve their potential. And that really is ultimately the goal of all of this, right? How do we be sure that every child reaches their potential, including children who may have some additional challenges? Now, one of the things I do want to just mention, because often people say, well, what's the definition of a child with special need? And I know there are some more formal definitions out there. For example, the federal government Maternal Child Health Bureau has a definition of children with special health care needs. But I think in this committee, we want to look a little more broadly when we talk about children with special needs and think about, this is inclusive of not just children for perhaps, often people think about a child with a particular medical need, but we want to also sure we include developmental and mental health issues as well. I know that my predecessor, Senator Steinberg, has been a huge champion for children with autism, and certainly I think that falls under this umbrella as well, and certainly that's a particular interest of mine as well. And we understand that we have children who are in circumstances where they're under tremendous, whether it's psychological stress or other types of situations, and that we want to think about how all these services come together and what we can do as a state. So what we're planning to do today in this very first hearing is really trying to map what the state does in terms of services and funding streams and so forth. And of course, some of that comes from the federal government. And then we also know that counties have particular responsibilities as well. And so we're going to look at sort of different layers, but particularly thinking about the state as sort of kind of like this, I guess, the sort of middle entity that either is passing on money or oversight or whatever, and certainly looking at what is out there right now, and also what the interfaces are between these different systems as well. Again, with parents not having to interface with many of them depending on their child's needs as well. And I think that's what we're going to try to explore today. And then from this foundation today, we are then going to start looking more specifically at different aspects of this one can call system, or lack of system that we have for supporting these children and their families. So this is just the beginning of this journey that we're starting on. But I'm hoping that this journey, as we go on it and we explore what's happening, will also lead to improvements. I know that I appreciate the interest and the people who have come to testify today, that be trying to think about what are opportunities we have to make things, to improve our organization or system of care. What can we do to reduce fragmentation? What can we do to better support families and their children? And let's look at what are the opportunities that we can create to actually try to put in better systems and better services, so that, again, our ultimate goal is so that every child will have the opportunity to achieve their potential. So with that, I want to again thank everyone for being here. And we're going to begin with Dr. Ed Shore. And I just want to particularly thank the Packard Foundation, both for their ongoing leadership in addressing the needs of children with special needs. Please come up here. And also for the Packard Foundation's support of helping provide us the background and technical support to help this committee advance its work. So I want to thank you again, Dr. Shore, and thank the Packard Foundation. So welcome, Dr. Shore.
Thank you, Senator Pan. Well, I'm pleased to be here today. As most of you know, the Lucile Packard Foundation generally focuses on children with special health care needs. I'd like to broaden that and follow the trend that you suggested, focusing more on systems of care. Let's see, let me bring up slides. Not happening. Okay. Bigger than a bread box here. How do we do this? No. Should be there. Okay, got it. At the Lucile Packard Foundation, when we talk about health, we generally use the World Health Organization definition, at least conceptually, that is really a broad understanding of health and well-being and the factors that lead to it. We appreciate, as does Senator Pan, that it really takes a system to address the needs of children, particularly children with special health care needs. I appreciate you can't see this completely from the back. It's pretty detailed. But we tried to produce here is a schematic showing all of the various components of a system. The big components that we typically think about are on the outside, and the smaller pieces are on the inside, and I'm sure it isn't complete. each of us, whether we have special needs or not, actually have our own system of care. We have our own doctors, we have our own dentists, we have an attorney or a CPA if we need one, we have recreation in our communities and so on. Most of us have one that is fairly straightforward. This is an example of the personal care system of one child with special health care needs laid out by his mother. Again, I'm sure you can't see the detail of this, but suffice it to say there are 30-some different people that this child and family interact with on a regular basis to assure the child's needs are met. Dr. Pan mentioned the systems that he's including in his conceptual model of a system. I've added to that the child welfare system, and we'll come back to why that is. I should point out these systems are run by separate agencies. They have separate budgets. They have separate regulations. So the fragmentation is built in from the very beginning of these programs and continues, and trying to figure out how we can integrate across them is extremely difficult and complex, particularly when we talk about there being both federal, state, and county dollars supporting these. A lot of negotiations would have to happen to figure out how to get these together. One of the arguments for getting these together is that if we don't take a discipline view, but in fact take a child-centered view, you're going to find out that many children are receiving services from multiple of these various departments and disciplines. Ironically, no one, as far as I know in the state, can tell me what the overlap is. We know that children in the regional centers get a lot of special education. I don't have any data on what proportion of those do. We know there's a huge overlap between the CCS program, mental health and developmental disabilities. I don't know how many of those are. So until we can kind of identify the commonalities, the shared responsibilities, it's going to be hard to start to coordinate. But I think that ought to be the basis of the coordination that we try to do and the system development we try to do. These are what I call the special needs of special needs children. They're the systemic needs that they have. And I don't usually read slides, but assuming these can't be read well in the back, I want to go over them. Every child needs a person that they contact that gets them into the system. Services need to be planned, and people need to be accountable for those plans. We have to acknowledge that multi-systems are involved. We have to have skilled professionals available. We have to all think about preventing progression, whether that's progression of health problems, progression of mental health problems, progression of social problems, and so on. We all need to think about prevention. Everybody has to have some special accommodation, whether that's longer time to take a test or it's giving a child a wheelchair. Everybody says that they agree we need family-centered services and supports. We actually need to build a system that builds that in. If we're going to integrate programs, coordinate programs, you have to have data, shared records that's readily available and is indeed shared. And we need to work on coordinating and ultimately, ideally, integrating services. The reason you need care coordination is that you don't have integration. So care coordination is kind of a bandage that we need to substitute for the lack of integration. We're probably a long way from integration, so I think it makes sense to focus on coordinating services. So regardless of the system we're talking about, these are some, I think, the key components of a high-performing system for children with special needs. They all have to take a whole child, comprehensive, coordinated approach to care. We can't say, well, I'm a doctor and therefore health is most important, and so you guys should send your information to me. It's got to be child-centered in that way. We have to have service plans that are integrated, and we have to share the information around those. We have to have meaningful family involvement, and I emphasize meaningful. I mentioned earlier, we need enough trained professionals to do the job. We need to have equity of access to good quality services, and we'll come back to that in the future. But in fact, there is now inequity of access based on geography, race and ethnicity, income, and so on. And we need to have monitoring of these systems transparent so that we can assure that quality is happening. Let me point out that I'm moving now to think a little bit more as a healthcare provider and from our foundation. Children get into the child welfare system because of their own or their parents' mental illness, substance abuse, post-traumatic stress disorder, chronic illness, are some of the things that lead. Those are health things that link to the child welfare system. Health things that link to special education or prematurity, genetic and congenital disorders, mental illness and chronic illness. And the same for developmental disabilities, prematurity, genetic and congenital disorders, neurologic disorders. Health is an issue throughout all of these other systems, and those need to be recognized, as does it need to go in the other direction. I'd be remiss not to mention that fundamental to all of these systems and needing these services is poverty. One of the things we've been seeing, certainly in the health system, but I think it probably is happening in all of the systems, is we're seeing an increase in the number of children with special needs. In the last decade, there's been about a 1% increase. 1% is a substantial number of children who are affected. Moving more into healthcare, the national surveys of children with special healthcare needs find that slightly over 10% of children in California meet their definition of special health needs. That's substantially lower than nationally. This difference is important because it tells us something about the need. The people who've analyzed this suggest the difference is that we are heavily Hispanic in this state, and Hispanic families are reticent to identify their children as having special needs. So once you look at the children who have more complex, higher levels of special needs, in fact, we look just like the nation. But when you're looking at the more less severe, it's lower. That means that we need to do a much better job of early identification of children in California if we're going to intervene effectively. When we've looked at that national survey to see how California's healthcare system is doing compared to the nation, we're not doing very well on an awful lot of indicators. Most of these are not indicators of subspecialty care. These are indicators of failure of access to good primary care and the services that we'd like to see all children receive. So this was a wake-up call for our foundation and hopefully is for the state agencies as well. As we try to move toward more whole child care, focusing on making sure that prevention and care coordination and other aspects of service are available to children in this state. At the foundation, we know that this is a very broad agenda, and so we're focusing on 4 topics. The first one that's actually getting the most attention from us is care planning and care coordination. When you look at families issues, that's first on their list. When you look at physicians, that's first on their list. We need to figure out how to do this, and it's not easy. But we need to solve this problem. Family participation is our second issue. Supporting families to help manage their own children's care is the next. And finally, is disparities in the quality of health care. And I actually want to focus on that one as I reach the end of my presentation. How do you know you have disparities in health care? One way is to look at what are the standards for systems of care. And then you can look at your system compared against those standards and see where you are in comparison to other systems. Your system could be a state program, it could be a managed care organization, it could be a hospital, it could be some other kinds of systems. But if you haven't benchmarked what your expectations are for the performance of the system, this isn't child outcomes, this is just the system should be there. So going back to the previous slide, If everybody believes that care coordination is so important to improving things for these children, then the system needs to be able to be providing care coordination services, and we ought to be able to measure that. If you look at this report, by the way, that's on our foundation website, which are national standards done by a national consensus group looking at system standards for children with special health care needs. Many of the standards apply to any other system, not just healthcare systems as well. There's a list of the system standards in categories, and as you look through it, if you're not coming from the health perspective, you will see nonetheless that most of these categories of standards apply to your system as well. In closing, I want to mention how can state agencies use system standards once you've identified them and agreed upon them. First is, I think you have to identify children with special needs as a special population in your programs and in policy. You can't just use a broad paintbrush to assume that these children's needs will be met by a broad categorical program. Secondly, you have to identify and reference national standards as you design your system and as you go to improve your system. You need to be monitoring adherence to these standards, seeing how well you're doing. Nobody reaches 100%, but the standards can be a really important tool to tell you where you are and where you ought to be. They also allow you to assess system performance and compare across systems. So you can compare managed care organizations, for example, or you can compare regional centers' performances. When you look at how you're doing against standards, that's a guide for where you might need technical assistance to improve performance. And finally, if everybody is using standards, you can create partnerships among all of your stakeholders, families, providers of all sorts, community service providers, policymakers, to figure out how best to monitor the access to these services and monitor the quality that's being received. So on our website, we have a lot of publications on these topics, so I encourage you all to look to them, and I'm happy to communicate with anyone at this email address if that would be helpful.
All right, thank you. Thank you so much, Dr. Shore. So I have a couple of questions for you, and I appreciate your presentation. It's the slide with where California ranks is a bit disturbing, because I saw a lot of 50th there. Reminds me of our Medi-Cal rates. So actually, unfortunately, also the Annie Casey Foundation actually also ranked us, I think, number 40 for children overall, not just children with special needs. But I understand you said the foundation actually put together and looked at how California fit in with some of these national standards. How easy or difficult was it for the foundation to get the data to assess where the state is, and also to what degree, and I don't know if there was missing data that you were unable to get as you were trying to figure that out, in terms of, I guess, if we have a goal, because you mentioned, say, let's create a dashboard or a standard, right, let's say, across all the systems that we could use to say how, let's say, a report card and how we're doing with children with special needs. Is that something that's possible?
We haven't done it. We've gotten to the stage of presenting this, and actually the grantee, which is the Association for Maternal and Child Health Programs, which is national Title V, has actually been developing some assessment tools that take those standards and turn them into an assessment instrument that can be filled out. I suspect some of the standards we have good data for, some of it we don't. I actually thought about creating a report card based just on my own opinions of how we did, but I thought we didn't want to start a food fight here today. But I do think that what you said is exactly the way to go. These standards can be the basis for, you can go through the standards and say, let's look at this one, and this one, and we'll use that for a report card for how we're doing. And they can be selected based on the availability of data, although there ought to be some selection process that doesn't just reflect that, because a lot of important things we don't have data on and we need to.
Well, I guess just to follow up then, part of the reason for asking the question isn't just to say that do we have all the data, we should only look at the things we have data for, but we will be hearing from various agencies and so forth that perhaps we should be asking, can we come up with the data for the things we don't think? I mean, we should be choosing the benchmarks for the things we think are important and then figure out how do we get the data so we can actually measure our performance.
Right.
So, okay. And also just, I mean, I know that you sort of, in terms of, again, looking at why we're doing so poorly, did you have any other thoughts? I mean, we talked about how things are fragmented, but why California in particular is doing so poorly?
Well, I think your comment that we're also 50th on Medicaid reimbursement plays into that. Most of those metrics that we're low on are not metrics for special health care needs or specialty care, although there's some there. Most of them are metrics on the fact that kids with special needs are not getting high quality primary care, and that we have two systems. We have a CCS system and we have a Medicaid system that are not linked in any particular way. And therefore, those kinds of issues, getting preventive care, having a regular source of care, and others are really, I think, a reflection of the separation of those key programs and the failure to be able to reimburse adequately for the primary care services that are necessary.
And just in terms of, I don't know, from your examination, the work that the foundation's done, are there particular states that you'd hold up as perhaps better models for the high-performing states? I don't know if there's particular states that you want to mention that might be ones we should be looking toward in terms of how they've organized that are performing better, or is no one really doing all that well?
There are some, but I'm not going to be able to pull it out of my memory at the moment. In general, you find that Iowa, Massachusetts, I'm going to forget the rest, but there are some. And